Hi, this is Jess again, and continuing my little mini chapters of PowerPoint videos. Now this video is going to be discussing delirium, something that I worked with a fair amount while I was on the ICU. And so hopefully we'll have a nice exploration of that particular problem together today in my little video. So, as always, thank you to Dr. Jones for allowing me to use her slides to talk to you about this. Her slides are amazing. So, there are three common problems in adults when it comes to cognition. There's dementia, there's delirium, and there's depression. So, this particular slideshow is only about delirium, BT-dubs. It's not about anything else, just delirium, which is an acute onset of confusion. So if you go into the Lewis textbook in table 59.1, there's a comparison, like a side-by-side comparison of all three, how they occur, what they look like. You should be aware that these problems can often occur together too. So you're not going to be like one and done, like, oh, it's only delirium, oh, it's only depression, oh, it's only dementia. People can often have, one, two, or three, a combination of all of these particular problems. The other thing that you should be aware of is people can like wax and wane in and out of delirium as well. Delirium is normally associated with some specific instances, and we'll get into that. So it's a sudden, temporary, acute mental confusion. So acute meaning it lasts 1 to 7 days. It can be life-threatening because these people have such a high amount of confusion that they end up making some very poor decisions and end up being either threats to themselves or other people. Or the delirium can also mask other problems, and they're bad reporters of other issues that they're having going on because of the delirium. So it happens about 50% in about 50% of people who are 65 and older who are hospitalized, and 80% of people who are in the ICU. And we use a lot of different medications in the ICU that like if you're on the ventilator and you've been in a medically induced coma, you're really likely to develop delirium when you're coming out of that medically induced coma. It results in disorganized thinking. It results in difficulty concentrating, and there can be sensory misperceptions associated with delirium. So the reason how we look at the difference between delirium and dementia is what was the patient like upon admission or before they had this acute problem, what was their chronic condition? If they're chronically disorganized in their thinking and having difficulty concentrating, that's a dementia problem. If they were not having any problems with disorganized thinking and not having any problems with sensory perceptions or difficulty concentrating, and then now they're in the hospital and they do, we have a delirium situation. So causes of delirium can include underlying dementia, dehydration, electrical imbalances, emotional stress, lung, liver, heart, kidney, brain disease, or brain problems, basically perfusion problems. If you don't have good circulation, you're going to have problems. And then you can probably see where the lung, liver, heart, kidney, brain all relate to any sort of electrical imbalances. Infections, ICU stays. R is for prescription drugs, injury or immobility, untreated pain, unfamiliar environments, and then metabolic disorders. These are all causes of delirium. So the causes of delirium are many, many, many. The symptoms of it though. So early on, what will happen is it'll take a lot to concentrate. So their inability to concentrate, they can be irritable, they may have insomnia, and they may have loss of appetite, restlessness, confusion. So in early signs and symptoms of delirium, it can look a lot like, anybody have problems sleeping or go with lack of sleep for a while? And so you're irritable and you're cranky, and this happens a lot around finals week. And when people have big papers due, right? They have problems concentrating and they're irritable, and they may have insomnia, they may have stress-induced insomnia, they may have purposeful, not lack of sleep, right? And then they are restless, they're easily confused, they may not be eating very well. However, what happens as this person progresses into later signs and symptoms is agitation, complete misperceptions, misinterpretation, and they'll have hallucinations as well. So these people may be seeing things that are not there, hearing things that are not there. Sometimes the most common sign or symptom of delirium that we had is our IV pumps used to make this really, when I was working in the hospital, they used to make this really weird whine that kind of sounded like when a cat wants your attention. It does that sort of like, I'm not a very good imitator of it, but they would be, we would have patients who would ask to let the cat out or get the cat out of the room, or can you just get, and then they would get more and more agitated because the cat wasn't in the room. There is no cat in the room, but in their reality, because that's what delirium is, it's a shift in reality. In their reality, there is a cat. So we need to work with them about that. So there's a diagnostic tool that we can use. You'll see it in table 5918. And really that is presence of 1 and 2, and then either 3 or 4. We can do a nice thorough H&P. We can do potential causes. Like I said, when I worked in the ICU, we were just always like, okay, what sort of delirium do we have? Not do we have delirium, what sort of delirium do we have? And it was more of like a rule out. Okay, I can rule out that you don't have delirium, but I'm just going to assume that everybody does. We also use tests to rule out. So labs, we'll take a look at their electrolyte panels, their kidney function tests, their liver functions. We'll look at their EKG and see if they're having any sort of cardiac rhythm changes. We'll take a look at their urinalysis, and then we'll take a look at their O2 sats as well. So to treat it, like, what do we do, right? So first, we're going to try and prevent it as much as we possibly can. After that, we are going to reorient them frequently, like, hey, Mr. Jones, it's Saturday. My name is Jess. How can I help you out today? We're going to be reducing stimuli so that they can perhaps get some quality rest and not have all of this everything coming at them all of the time. Stimuli, everything coming at you all of the time in a strange environment can create delirium. So if we can minimize that particular factor through environmental interventions, it'll be much better for everybody involved. We'll make sure if the person is a watch wearer that they have their watch. We'll make sure that the wall on the clock on the wall is accurate. We can also get them a calendar. The communication board should be updated with days and dates all the time. Getting them any sort of sensory aids like hearing aids and glasses makes a huge amount of difference. Bringing the family in for support can really help too. So as long as family isn't getting too overwhelmed and being counterproductive to the delirium, because that can totally happen as well. Excuse me. And then, like I said before, if we can reduce the stimuli as much as possible, that's amazing. Perhaps like on the ICU, when people started exhibiting signs and symptoms of delirium, we would do our best to move them from the wall-mounted monitor system that had alarms that would go off in the room to a portable telemetry box where the alarms were going off at the telemetry station. And that was one of those ways that we could reduce stimuli. We would also try and cluster our cares so that people weren't constantly being woken up they could have an hour, hour and a half off from staff interaction, and then be able to come back to that as well. Let's say all that doesn't work and we're in a severe situation. So in severe situations, what we're going to be doing is we're going to be, and it's not, severe situations don't mean really bad confusion. Severe situations mean they're a threat to themselves or they're a threat to those around them. So they're starting to have safety concerns. And if we can't do those non-pharmacological interventions, like I had said on the last slide, that's when we move into these particular situations. So we can use some low dose antipsychotics. I'm laughing at vitamin H there. Haldol, we practiced, all of us practiced drawing up Haldol this in skills lab not too long ago. You can give that IV, you can give that IM, you can have them take pills. There's also a few different other pills that they can take as well. Risperidone, Zyprexa, and Seroquel are available oral, and I think they might be available IM as well, but don't quote me on that. Definitely look at your book. For people who are having severe delirium related to alcohol withdrawal and they're on the CWA protocols, or if you notice some delirium happening, start asking questions about how often they drink, because you can have people who are going into detox situations who aren't in the hospital for detoxing. Like they came in for a scheduled ankle surgery and all of a sudden they're having delirium activity. It could be because they are having alcohol withdrawal and it's not related to their ankle surgery at all. When those particular situations happen, for alcohol withdrawal, we have Ativan available. Ativan comes in tablets and it comes in liquid form, and it comes in IV form or IM form. So there are times where people are getting super huge, large doses of Ativan. The people who are dosing with Ativan really need to be trained nurses in terms of alcohol withdrawal, because some of those Ativan doses can be quite large. That ends the delirium section of my talk for today. I'm going to stop sharing. And I will keep recording, and so that you can keep learning during asynchronous learning week.